So as this audience is well aware, we and our patients struggle to provide lifelong antiretroviral therapy to perinatally infected children and adults. Early in infancy and childhood, there may be drug resistance associated with PMTCT treatment, and then later in life, our patients experience adherence difficulties during adolescence. Within the Asia region, there are many countries with accessible second-line antiretroviral options, but third-line drugs are often inaccessible or extremely expensive outside of compassionate use programs. We needed more data on second-line regimen durability, failure, and resistance if we were to better understand how and when to switch from second-line. The study we implemented was aimed at evaluating immune and virologic responses, adherence, and resistance mutations in those who were already on or switching to second-line regimens, as well as assessing susceptibility to third-line options if those were needed. We included children who had been infected in early childhood as long as they were under pediatric care at our participating sites. The switch criteria required a major class change for what local clinicians considered was treatment failure. We excluded children who had been exposed to initial mono or dual NRTI regimens, whose first failure was a triple nucleoside combination, and who switched for known toxicity and reasons other than failure. We also excluded those who were on non-standard regimens, specifically those who were on once-daily lopinavir or mono or dual therapy with only protease inhibitors. After enrollment, children were assessed every 6 months up to a maximum of 120 weeks. If virologic failure was identified at a threshold of 1,000 on a single test, samples were sent for genotyping and therapeutic drug monitoring, which I will abbreviate as TDM. Viral suppression was based on being below the lower threshold of the local assay, which ranged between less than 20 to less than 400 copies. We evaluated adherence using pill counts and visual analog scale, and analysis of risk factors associated with virologic failure were also conducted. Between March 2011 to December 2012, 277 children were enrolled at 8 sites in 3 Southeast Asian countries. A small percentage were switched at enrollment, and 88% were already on second line. We were able to collect retrospective clinical and lab data for most of these children during the time since second-line switch, with some limitations that I will mention later. The analysis was restricted to the 274 children who had at least 6 months of follow-up. Patient characteristics are shown here for the time at second-line switch and at the last study visit or virologic failure. A little less than half of the patients were females who are a median of 7.5 years old at the time they switched from first line. Less than half were in WHO stage 3 or 4 at the time of switch. All of our patients had failed NNRTI-based first-line regimens, and almost all went on to start boosted lopinavir regimens. The 20 patients not on lopinavir at the last visit or viral failure in the second to the right column were on atazanavir. At the time of switch, they had been on ART for a median of 2.7 years and had a CD4 of 300 cells or 13%. At the last visit or viral failure, the median time on ART was 3.6 years. The CD4 had risen and the viral load had fallen over time, but please keep in mind that these numbers reflect a combination of patients who were both suppressed at the end of the study and had viral failure. This Kaplan-Meier graph shows the probability of viral failure after switching to second line over time with years post-switch on the x-axis. Overall, 73 patients, or 27%, had at least one viral load over 1,000. The median time on second line to first viral failure was 2.4 years, with an incidence of 7.3 per 100 person years. This table is a little bit complicated, but it does describe the viral failures after second-line switch. As none of the patients were switched to third-line regimens during the study, we were able to monitor patients and document a second viral load test over 1,000 in 40 of the 73. Sorry, that's just above that red line. And then a third elevated viral load test among 23 of those 40. The sex distribution mirrored the female to male ratio in the overall study population. The median age was 11 to 10 years at the time of the elevated viral loads. The median CD4% at the time of failure was 22% down to 15%. The median viral loads were about 4 log or higher, and the time on second line was about 2.5 years up to 3 years. 4 were on atazanavir and the rest were on lopinavir. Between 52, although all had elevated viral loads, between 52 to 73% had pill counts reflecting over 95% medication use or visual analog scale reports over 95% adherence. As some of the patients had their first viral failure before study enrollment, only a subset had plasma available for TDM, which was done for the protease inhibitor in their regimen. About 1/4 of those with available TDM after the first failure, or 16% of all patients with viral failure, had drug levels below the lower limit of quantification. Almost all patients with a second viral load over 1,000 had TDM samples available, and half of them had no quantifiable drug in their plasma sample. This was similarly the case for those with a third elevated viral load. With regards to genotyping, we had genotypes for about 70% of those with one viral load over 1,000. For the second elevated viral load, we had 75% of genotypes. The incomplete genotyping rates during study follow-up were largely due to problems with the samples and the genotyping assay. This figure shows the mutations that were detected after the first elevated viral load in blue, after the second elevated viral load in red, and the third in gray. The mutations are characterized into having more than 6 lopinavir mutations, any major lopinavir mutation, any major atazanavir mutation, and any major darunavir mutation. The percentages of those susceptible to lopinavir by the Stanford interpretation are at the far right. Overall, there were low levels of resistance detected. Looking specifically at the major lopinavir mutations, at the first elevated viral load, 8% had a major mutation, and this was almost the same on the second elevated viral load and went to 15% for the third. From 80 to 86% of those with elevated viral load remained susceptible to lopinavir. Although the data are not shown, this high susceptibility was also seen for atazanavir in the 4 patients who were on that regimen. There were 2 covariates found to be independently associated with failure: age at second-line initiation of greater than 11 years with a hazard ratio of 4.1, and viral load at second line of over 5 log with a hazard ratio of 2.4. Sex, duration on first line, weight, height, clinical stage, and CD4 were not significantly associated with failure. Unfortunately, we were not able to include adherence in the Cox model because we were missing adherence data for those who started second-line regimens before study enrollment. In summary, 70% of our patients were able to maintain virologic suppression over more than 3 years of study follow-up. Of those with a viral failure at the 1,000 copy threshold, only up to 15% develop major mutations to second-line PIs, even after up to 3 elevated viral loads over 1,000. And half of the patients with 2 or more elevated viral loads had unquantifiable protease inhibitor levels, showing that the repeat viral failures and the low levels of observed resistance were frequently related to very poor or non-adherence and limited drug pressure on the virus. Moreover, it appeared that the visual analog scale and pill count were not reliable indicators of adherence when compared to viral load and TDM in those with failure. However, we also observed that those with only a single elevated viral load were able to resuppress their virus. Our findings emphasize that the subset of adolescents who are repeatedly having high viral loads need more adherence support. Viral load testing helps us to identify those at risk of failure, but we need effective adolescent-specific tools to motivate them to take their medicines. And again, I think that this is a message that many of us who see patients in the room are all challenged by. So I'd like to thank all of the people who supported the study, our patients, study staff, and clinical laboratories, as well as Azara Karamini at the Kirby Institute for her help with the retrospective data, and our funders at Viv Healthcare, the US NIH, and AIDS Life for making the study possible. Thank you for your time.